Good morning, ladies and gentlemen. I would like to thank the organizing committee for putting together this incredibly interesting meeting about unloading. And also I would like to thank the reviewing committee for giving me this award that really, is a testament to all the work that all our group has done, particularly with Dr. Hayar and Dr. Ishikawa. The heart has like a very small content of ATP that actually would be finished in around 10 seconds. That's why, in order to meet the exceedingly high metabolic demands of the continuous contraction, the heart has to continuously produce ATP. And in a normal heart, this is done by 90% oxidative metabolism and only 5% anaerobic glycolytic metabolism. The heart actually also possesses metabolic flexibility. It's an omnivorous and can catabolize different types of metabolites, of fuels. So, free fatty acid, glucose, ketone bodies, pyruvate, lactate, amino acids, mainly branch chain amino acid. But basically, most of the ATP production of the heart, between 60–80%, comes from free fatty acid in the normal heart, and around 20–30% from glucose, and the rest from the rest of the metabolites. And we can see here how all these metabolic pathways coincide in the oxidative metabolism, how the glucose is metabolized into pyruvate and will go into acetyl-CoA and into the Krebs cycle, but can also branch out to lactate and anaerobic metabolism, how the fatty acids also are incorporated into the Krebs cycle, and how finally ketone bodies, both beta-hydroxybutyrate and acetoacetate, are also incorporated into the Krebs cycle. So the energetic status of the myocardium is impaired in heart failure. And famously, the failing heart has been described as an engine out of fuel. So an abnormality, if we see here in this table, if we burn 1 mole of glucose, only 224 kilocalories are produced. However, if we burn fatty acids, such as palmitate, 25% more of ATP will be produced, almost 300 kilocalories. Therefore, fatty acid, that's the main substrate of the heart. And that's why abnormalities in myocardial energetics will both cause and contribute to heart failure. So as free fatty acids produce so much ATP, any reduction in free fatty acid metabolism will cause left ventricular dysfunction and heart failure, and this has been demonstrated both in humans, treated with acipimox, that acutely inhibits free fatty acid metabolism, and also in animals, knocking down the enzymes responsible of free fatty acid metabolism. So if we impair fatty acid metabolism, that will cause left ventricular dysfunction and heart failure. But also, please note here in the table how fatty acid produce a lot of ATP, but at the expense of high oxygen requirements. So in a situation of increase of relative hypoxemia, such as increased overload because of failing heart, the heart will not have enough oxygen to metabolize the fatty acid, and therefore will experience a metabolic switch toward glucose consumption that is a much more oxygen-sparing molecule. This is positive in the short term because we are allowing the heart to survive by using less oxygen, but in the long term that is negative because we are producing less ATP, and therefore that will create a vicious circle. That's why in the chronic heart failure, there will be what we call metabolic remodeling, with a reduction in myocardial consumption of fatty acid and an increase in myocardial metabolism of glucose. This has been exhaustively demonstrated in animal models and also in humans. Classically, we had always considered that this increase of glucose metabolism was due to an increase of glucose oxidation, but lately we have also realized there's a mismatch between glycolysis and glucose oxidation, and that this excess of glucose consumption by the myocardium is metabolized through the anaerobic pathway, not so much through the glucose oxidation. Ketone bodies are also an important metabolite. Ketone bodies are the most energetically efficient metabolite for the heart, and in fact, if in a working heart model we add ketone bodies to the perfusion, we'll see an increase in the heat of combustion by 31%. Also, if we enhance ketone cardiac metabolism, we'll see that the heart failure in animals will improve and ejection fraction will go up, and while conversely, if we impair ketone myocardial metabolism, even healthy animals will end up developing heart failure and reducing ejection fraction. This is very important, and we have recently realized that failing myocardium not only consumes not only can consume ketone body, but that actually the ketone body consumption is increased at least 3 or 4 times in the failing myocardium. And ketone bodies are very important also to explain the mechanism of action of the SGLT2 inhibitors such as empagliflozin. And we have recently demonstrated that the cardiac benefits of empagliflozin are due to a switch in myocardial metabolism away from the energy inefficient glucose into the more energy efficient ketone bodies. And well, in some previous experiments that we did, we see how normal pigs, non-heart failure, they do not consume glucose. They consume a lot of glucose when they develop heart failure, but with empagliflozin, this is reduced. And also, and this is parallel by the changes in ketone metabolism, no ketone metabolism consumption, but there's a lot of ketone metabolism consumption with empagliflozin. So, having in mind the central role of cardiac energetics in heart failure, our aim was to investigate the effects of the different loading conditions on myocardial metabolism. And since unloading with Impella will decrease the ATP requirements of the heart, we hypothesized that this acute unloading would at least partially reverse the metabolic derangement of the failing heart, meaning that it will ameliorate myocardial metabolic remodeling, will reduce glucose consumption, and will probably reduce the anaerobic consumption, the anaerobic pathways in the heart. So for this, we evaluated the transcardiac gradient. So we cannulated both the coronary arteries and the coronary sinus. We obtained simultaneous samples, and we calculated cardiac gradient as simply difference between arterial and venous concentration of the metabolite. And we studied this transcardiac gradient in 3 different models. First, in sham animals, animals without heart failure. Second, in animals with acute overloading, with heart failure plus acute overloading with aortic regurgitation. And third, in animals with heart failure plus acute unloading with Impella. In this slide that Dr. Ishikawa has presented previously, we can see a summary. First, we create the infarction. 1 week later, we obtain blood baseline. Then we create the acute overloading with aortic regurgitation or the acute unloading with Impella, and 2 hours later we will collect again the blood samples to see different in transcardiac gradients. As expected, myocardial infarction results in an increase in left ventricular volumes, a reduction in ejection fraction, and the creation of scar as determined by TTC. How do metabolites fare? So 1 week after infarction, when heart failure has already been developed, we see a reduction in the free fatty acid metabolism of the heart. We see high fatty acid uptake by the myocardium in the healthy myocardium that is reduced in the control animals. While conversely, glucose myocardial uptake is low in the healthy myocardium is increased by 6-fold in the heart failure. If we analyze further metabolites, we can also see that lactate experiences a lot of changes. So baseline, there is some consumption, some low-grade consumption of lactate, but in the failing myocardium, what we see is a complete reversal of the transcardiac gradient, meaning that now there is like a net production of lactate in the myocardium, which can only be explained because of this increased glucose uptake, but the myocardium is metabolized through glycolysis. And ketone bodies, that there's low consumption of ketone bodies baseline, is increased, is double in the failing heart, but although there is a trend, this does not reach statistical significance, probably due to the low sample size. So when we acute overloading results, as expected, in an increase in left ventricular volumes and pressure, and a trend toward an impairment of left ventricular systolic function, and also a rightward shift in the pressure volume loop. If we focus now on the metabolites, we can see that this acute overloading worsens metabolic remodeling because there will be a doubling of the already altered myocardial glucose uptake. So please notice how the normal myocardium does not consume glucose. This is increased sixfold in the heart failure, and with just 2 hours of overloading, this glucose consumption is double. And this increase in glucose uptake is also paralleled by the increased enhancement of the anaerobic glycolytic pathways. As we can see here, there's no lactate production in the healthy myocardium. There is lactate production, meaning anaerobic metabolism, in the heart failure, in the failing myocardium. But again, this is more than double. The net lactate production by the myocardium is more than double with just 2 hours of acute overloading. Regarding free fatty acid consumption and ketone bodies consumption, we did not really see a change with overloading. So there was like a reduction in free fatty acid in the failing myocardium, but this was not really altered with overloading. And with ketone bodies, there was like an increase in ketone bodies consumption by the myocardium with the failing heart, but this was also not really changed with 2 hours of overloading. We don't know with larger periods of overloading. And left ventricular unloading also, as expected, results in a reduction in left ventricular volumes and pressures and a leftward shift of the PV loop curve that also acquires like a more triangular-like conformation. And as we hypothesized, as the cardiac output is mainly, obtained through Impella flow and not so much through the native heart, the metabolic requirements of the native heart would be, at least theoretically, reduced. And the glucose consumption, as we hypothesized, would be reduced. And this was confirmed in our experiments. We can see this is the failing myocardium with a lot of glucose consumption, but the myocardial glucose uptake was reduced by just 2 hours of acute unloading. And this is also parallel by the improvement in the glycolytic pathways as seen here by lactate metabolism. So there is net lactate production, net lactate release by the heart in failing heart, and this is almost reversed by just 2 hours of acute unloading. If we focus on the other metabolites, we did not really see a difference. So we can see here that the free fatty acid, there's like a reduction in the failing heart, but that does not change with acute unloading, and ketone bodies, again, this does not change with just 2 hours of acute unloading. So this is very interesting because there has been previous publications, one publication from the group from Christian Schulze when he was in Columbia, showing that there was an improvement in fatty acid metabolism with left ventricular assist device. Now, we have not observed this in our model, but I think that this is simply due to experimental differences. In his article, those patients have been supported by LVAD for more than 6 months, while our animals have only been supported by Impella for 2 hours. And obviously, in more than 6 months, you have time, for all enzymes of the fatty acid metabolism to be upregulated again and to be able, to reverse this mechanism. While in 2 hours in our model, that was not enough. And regarding ketone bodies, the temporal design of our experiment kind of explains this. The main determinant of ketone bodies uptake by the different organs is the plasma concentration. So in 2 hours, there has been not enough time for the liver ketogenesis to be altered, and that's why we are not seeing differences in ketone bodies, in myocardial metabolism ketone bodies. So, as conclusion, the failing heart show myocardial metabolic remodeling characterized by reduction of fatty acid consumption and increase in glucose uptake and lactate production, meaning that this excess of glucose uptake is not metabolized through glucose oxidation, but through anaerobic glycolysis. Left ventricular overloading will aggravate this metabolic remodeling, but left ventricular unloading seems to ameliorate cardiac metabolic remodeling, inducing a reduction in glucose consumption and a reduction in net lactate production. So left ventricular unloading in heart failure is able to acutely and rapidly shift myocardial fuel utilization. And well, I simply want to acknowledge all the people who has participated in this work, both from Dr. Badimon's lab and also from our wonderful collaboration with Dr. Ishikawa and Dr. Hayar. So thank you very much for your attention.
Carlos, thank you for that very intriguing work. I think we just have time for one question, and it looks like, Naveen, you're it.
Yeah, this is a phenomenal talk, really exciting stuff, and it's great to see this penetration into metabolomics that you're doing. So one question I had was, a couple of questions. One is, did you look at the tissue level? You have the blood, you have the transcoronary gradient to measure the blood sampling, but can you tell us a little bit about what's happening in the tissue, or if you have future studies planned to look at the tissue itself? Because you have an infarct zone, you have a non-infarct zone, a peri-infarct zone. Do you think it's a global event, or do you think it's a regional event? And then the second question is around the substrate utilization. Do you think there's an opportunity? You showed one pharmacologic intervention to modify metabolism in a favorable way. Do you think that also can be applied in combination with the device therapy to enhance the effect, or to replace the device therapy with a drug effect?
Okay, so regarding your first question with tissue data, we do not have tissue data specifically in these preliminary experiments. We are now doing additional experiments and we will collect this, but here we did not collect because those the previous experiments that we did obtaining endomyocardial biopsies, they were not really of good quality. So the results that we got with endomyocardial biopsy, the mRNA content, for instance, there was a lot of variability, so that's why we decided not to study this, because we did not really trust those data. For this, we would be able to do parallel groups in order to obtain solid and comprehensive myocardial samples. What we have seen in our experiments with empagliflozin, regarding your one big question about how the different parts of the myocardium are affected, is that the scar is not so much affected. So basically the scar is pretty much fibroblast and collagen. So the metabolism there is not so much affected. What we are seeing predominantly affected is all the remote non-infarcted area. There we have been able to see, for instance, we saw like a reduction in glucose uptake, and we also saw a parallel reduction in the levels and activity of PDH, of pyruvate dehydrogenase, which is the main enzyme catabolizing the glucose metabolism. We also saw a reduction in LDH levels and enzymes, and as we also saw an increase in ketone body consumption, we also saw a parallel increase in both activities and expression of BDH1 and SCOT, which are the two main rate-limiting enzymes regarding ketone body's metabolism. Regarding your second question about the combination therapy with these metabolic switchers and devices, I think that would be, really interesting. I do not think that these metabolic switchers will be able to completely replace device therapy. I think that we still have many patients that come in a very acute situation, and this will be device therapies will be needed, but also. I have a talk about the acute effects of ketones now in AHA on Sunday, so I cannot talk, because of disclosures, but I can only say that ketones have also like an acute effect, so could be some potential therapy also for the acute phase.
Dan.
I'm sorry.
Dan really wanted to ask one more question.
My question really relates to something that you just breezed over in the last response, which is pyruvate dehydrogenase, which is really, isn't that the key to this whole thing? Because in ischemia, PDH is inhibited, and that's what's driving lactate up, and also there's no oxygen for doing oxidative metabolism. So does this get back to, so what happened to PDH? It sounds like PDH is not up, activity is not disinhibited. And, this relates to, again, to a lot of stuff that was done a long time ago with GIK, glucose, insulin, potassium, and also dichloroacetate DCA, which really tried to, open up pyruvate dehydrogenase and get this. So isn't this? It seems like in the acute setting, as you differentiate it from the chronic setting, where you have real remodeling of these pathways. Here it's acute, and it just seems to be just related to that one enzyme inhibited, or is it more complicated, do you think?
Well, that's a wonderful question, because as we have not obtained tissue samples, we are not able, in these preliminary experiments to really determine, well, not the expression of PDH, because obviously in the short term that would not be effective, but the activity. So right now we cannot speculate about it, but I think that truly the PDH activity or expression is one of the main determinants of metabolism and return to a more normal metabolism, if you want.
So now we really, Carlos, let you go. And thank you very much, Carlos, and congratulations.